Hey, BC here. Welcome. Today I'm going to be talking about proteinuria, how I think about it, how I rate its severity, and how I treat it. So first of all, there's all these different ways to assess protein. There's urine protein creatinine ratio, albumin creatinine ratio, 24-hour urine protein. So what's the deal here? So the deal is this. The main protein in the urine is albumin. It's about 60%. So your albumin to creatinine ratio should be about 60% of your protein creatinine ratio in most kidney diseases. Anyways, in most glomerular diseases. If that ratio is off, if it's less than 40%, much less than 40%, you have to think of something else going on than a glomerular disease. Maybe there's a tubulointerstitial disease. Maybe there's Benz-Jones proteinuria, and you have to think about myeloma. But typically, we're thinking about 60% albumin albumin to protein. Now, what's the deal, microalbumin versus albumin? So when they first started developing this microalbumin creatinine ratio, before that they just used urine dipsticks, and the protein either showed up in the dipstick or it didn't show up in the dipstick. And then they invented this assay that could find find albumin in the urine, even if the dipstick was negative. So there was a very small amount of albumin, too small to pick up on a dipstick, so they called it microalbumin. So now the experts, the guidelines, they don't like that we call it microalbumin, so they think people are going to think it's very small albumin as opposed to a very small amount of albumin. So they want you to get away from it, but people still refer to it microalbumin creatinine ratio, albumin creatinine ratio. It's the same thing. So the deal is, and then if it's not microalbuminuria, it's overt proteinuria. So the other thing is what's the deal with the 24-hour? How do you correlate a ratio to a 24-hour? The deal is this. This is how you correlate it. If you make an assumption that the patient has 1 gram of creatinine in a 24-hour urine, if they pee 1 gram of creatinine, if you make that assumption, then the protein creatinine ratio or the albumin to creatinine ratio would equal the amount of albumin or protein in a 24-hour specimen. Now that's not always the case, because the amount of creatinine in a 24-hour urine is going to be based on the patient's muscle mass. So for a younger, more muscular person, it'll be higher. For an older, less muscular person, it'll be lower. But that's the assumption we make to grade it. So how do we grade it? So normal albuminuria is microalbumin or albumin creatinine ratio less than 30, and that turns out to be a protein creatinine ratio less than 150. That's normal. So then the first range is microalbuminuria. I'm still going to call it microalbuminuria. So that's going to be 30 to 300 microalbumin creatinine ratio, and that's going to be about 150 to 500 protein to creatinine ratio. Then if it's overt proteinuria, the microalbumin creatinine ratio is going to be greater than 300. The protein creatinine ratio is going to be greater than 500. Now, the deal is this. If the protein creatinine ratio or 24-hour urine protein is greater than 1 gram, and you can't get it to less than 1 gram with medications, then most kidney doctors, most nephrologists are going to think about doing a kidney biopsy. So we like that cutoff there. And then there's nephrotic range. So a nephrotic range proteinuria is going to be greater than 3.5 grams in the 24-hour urine. We're calling it a protein creatinine ratio greater than 3.5. And this is will correlate to an albumin creatinine ratio of greater than 2200. So there's the deal. So then how do I treat it? So in my experience, in my opinion, if someone's in the microalbumin range, I'm satisfied with just trying to keep it there, keep it from progressing to the overt range. If I can get it back to normal, that's cool. But if I can't get it back to normal, I'm not going to be going crazy with all these added 3-4 meds just to get it to the normal range. If someone's in the overt range, I'm going to try to get them back into the micro range. So I'm going to try to get the, if they have overt proteinuria, I want to get it the microalbumin creatinine ratio less than 300, protein creatinine ratio less than 500. And I may add multiple meds here to try to achieve that. If I can't get it, if they have severe proteinuria and I can't get it less than 500, it's all continuum, lower the better. if I can't get it less than 500, I try to get it less than 1,000. In that case, that helps. And in nephrotic syndrome, where someone might have 8-10 grams of protein, therapeutic, if you can get it to less than 50% of the baseline, there's evidence that that helped the patient. So those are some goals about what to do and how I do. Now the meds. Now there's 4 different types of meds to think about in my experience. Now the first one we all know about is ACEs and ARBs. So patients should be on an ACE or an ARB unless there's some absolute contraindication. Then there's some of the add-on medications. So I'm thinking about some of these add-on medications for the people in the overt proteinuria range, or if they need blood pressure control anyway, I might think about those. So next one you don't hear about, but it's true, is thiazide diuretics. Adding a thiazide diuretic will help to an ACE and ARB will help proteinuria. First of all, anyone who is, anytime you lower the blood pressure, you're going to help proteinuria, and thiazides actually are beneficial in this regard. So I have a patient, overt proteinuria, on an ACE or an ARB. Their potassium is high, mid-normal to high normal, blood pressure not controlled. I'm thinking thiazide, I'm thinking chlorthalidone. Next type of drug to add is actually spironolactone. Likewise, helps proteinuria, helps blood pressure, and I think also helps proteinuria, maybe independent of that. So I'm thinking of spironolactone in a patient, especially already on an ACE and ARB. Their potassium I would think went in the low range of normal, mid to low, and hypertension. I'm thinking about using spironolactone here. Have to be careful. The combination ACE and ARB with the spironolactone can result in some hyperkalemia. Need to monitor that closely. Next class of drugs is SGLT2 inhibitors, the diabetic drugs that make you pee out sugar, and they also help proteinuria. And they have an indication for non-diabetic CKD. Now, in my opinion, the real benefit of these drugs is in non-diabetic CKD is the people who are with overt proteinuria. First of all, my review of the literature says this: it's an add-on drug. Patient already on an ACE and ARB, you add it on, and I'm not convinced of the benefit, at least any benefit that's worth the side effects or the expense in patients with microalbuminuria or normal albuminuria with CKD. So I'm thinking about this drug in a patient with overt proteinuria, already on an ACE or an ARB, maybe already on a thiazide or spironolactone as well, and still has overt proteinuria. Maybe their blood pressure is already at target. I'm thinking to add it on if there's not a contraindication in these patients. Last class of drugs here to think about is something called Finerenone. Goes by the brand name Corindia. This right now is licensed for diabetics. And it's like spironolactone. It's a mineralocorticoid antagonist, but it doesn't have the same effects on lowering blood pressure or raising potassium. It does these things a little bit, but not so much as spironolactone. So I'm thinking about this drug in a diabetic who's already on an ACE or an ARB, maybe also already on a thiazide, can't use spironolactone because their potassium is a little bit on the higher side, or maybe their blood pressure is already controlled, and you don't want to do the added lower the blood pressure there. So that's where I'm thinking about those things. So that's how I think about and approach proteinuria. Have a good one. Thanks, man.